Welcome everybody. So it's a delight to be here today to kick off the U.S. section of our summit, our Digital Health and Mental Well-Being Summit in the world of social distancing. It's an unusual time. I mean, you know, I've been to many conferences, spoken in quite a few of them, and it really is the first time to really be in an environment that it's all digital, not just some of it is digital, and also to have people here from all over the country and speaking, you know, from their homes for the most part, but we can see that some of us will be speaking directly from their workplace, and some of them are on the front line indeed. So we're excited to have everybody here, and you know, this is a trying time for all of us, and one that it was completely unexpected in so many ways. You know, I started my discussion with Lara Stein, who's the founder of Boma Global, but also was the leader and the first curator of TEDx, the TEDx movement that started an idea back in 2011, and I still remember the early days of TEDx when Lara started the project with Chris Anderson from TED, and they had a vision of what it will become. And I was offered to run TEDx Silicon Valley, which was one of the first ones. And it was a wonderful, wonderful experience to see how something that started as a small idea became such an amazing movement of tens of thousands of conferences all over the world. And I'm excited that Lara is continuing the tradition with actually continuing to produce high quality conferences on Boma Global. You know, I continue to start a company and started Health App that has grown to become successful, and also to very recently start a new club at Stanford University that is called Live Long and Flourish. And the reason I'm telling you that is that the context of this conference started way back in January this year, early in January, when we were looking into an interesting trend that back then was somewhat concerning, that started in China, in Wuhan. And we said, you know, part of Live Long and Flourish is not only, you know, to live well, to eat well, to exercise, to practice brain and mind things, to live a healthier, happier, longer life, but also to manage risks. So as an example, back in January, to managing risks, we chose COVID-19, which was a nascent virus that started creating quite a bit of havoc in Wuhan, as an example of something that we believe needs to be managed. And it's kind of interesting to see how it's all snowballed since the beginning of January. But you know, we you know, start talking with experts at Stanford and beyond, Gary Skolnick and experts in Africa and in Europe, and we interviewed them and then brought them to a conference that we organized at Stanford early February, and the main topic there was coronavirus, and we were fortunate to have a conversation before it actually started becoming top of mind to most of us, and really wrote about it and talked about it, and that really was the impetus of where, you know, we are today. So we've been in this topic for quite a while, and had a discussion with Lara about, you know, producing a conference that will focus on this. They did it a couple of weeks ago. It went really well generally on coronavirus and COVID-19, and this one is actually dedicated to particularly digital health and mental well-being, which is obviously my biggest passion, and the passion and the profession of the wonderful panelists that we have with us today. So without further ado, we're going to talk more about the topics as we go. But first and foremost, I really want to introduce the panelists here. I'll say a couple of words about each, but then I'll open it to you guys to say a few words about yourselves. And you know, I'll start with Dr. Peter Yellowlees, who's a professor, a clinical professor of psychology in UC Davis, but also you know, he was a past president of the American Telemedicine Association. He's a writer, he's a clinician, he's a technologist, right? And you know, great career with so much expertise that is very, very relevant to what we're doing today. So thank you for joining us, Peter. I'll give you the microphone in just a second. Continue introducing the other panelists. We also have with us today Dr. Jeff Livingston, and Dr. Livingston is the CEO of MacArthur OBGYN. He's a head surgeon in Bailor Medical Center, Irving, Texas. I know Jeff for many years, and Jeff, beyond running a very successful network of clinics, is also still practicing, surgery and OB-GYN and helping women every single day, and you bring the perspective of a practitioner in practice, not necessarily dealing with COVID issues every single day, but dealing with the situation as it unfolds. We also have with us another doctor, Dr. Josh Reef. Dr. Reef, or Josh, is the CEO of Onduo, the very successful startup. He will tell you more about that. Is a former executive at Anthem, the insurance company, CVS, Target, and has also a very extensive viewpoint on what's going on today, and also where we're going from here, because today we'll discuss a lot, not only the current situation with COVID-19, but also about the transition into a new world and what are the opportunities for a better world from here going forward. So thank you for joining us, Josh, as well. We also have Dr. Reed Tuckson. Reed is also a former executive in United Healthcare. Welcome, Reed. And thank you for joining us. Do we have still Reed on the line with us together?
Yes.
Okay, wonderful. Reed is here. He was also the head of the American Medical Association at one point, and was the president of Charles Drew University and Medical Services Medical School in Los Angeles as well. And he joins us today to give us, again, several very important perspectives on where we are. Another former executive of a large company, at this time from Qualcomm. We have Donald Jones. Don, are you with us on the line? I know that Don had a little bit of a technical difficulty this morning. I'm just checking in with Don.
I'm here.
Okay, wonderful. And Don is the chairman of the Caridff Ocean Group. You can see the ocean in the background. He's also the chief digital officer of Scripps Research Translational Institute. And he served on many boards, and really will bring us the technology aspect of things, devices, and several very interesting approaches that will help us understand the topic of digital health on a broader perspective. And we also have with us today a special guest, Dr. Candace Robinson. And we are very pleased, very delighted to have with us today Dr. Robinson. She's the Chief Medical Officer and the Medical Director of Emergency Department in New Orleans East Hospital. And if there's something that really inspires me, right, in this situation, and really brings to life something that, you know, has been very near and dear to my heart for many years, is the role of you know, the medical professionals, the healthcare workers, the doctors, the nurses, the people who are really on the front line of what we're doing here. And she's really doing a remarkable job on the front line. I mean, we know what's happening in New Orleans. We know what's happening in New York, literally on the bleeding edge of the current crises. And what would we do without these unbelievable people that are day in and day out, night in and night out, literally around the clock, you know, helping, doing everything that they can, and really saving lives and keeping us all together. And I think that's pretty incredible. And Dr. Robinson, just checking that you're there with us as well.
Yes, I'm here.
Wonderful, wonderful. So why don't we start with you, Dr. Robinson? I think that, you know, I'd love to hear your perspective, you know, a little bit about you, a little bit about your experience, particularly in the past, you know, month and a half of what we're seeing out there, and really, like, I'll give you the microphone, and just please do share with us your experience. And then just to say, you are speaking right now from the hospital itself in New Orleans. So I really appreciate you taking the time. That means a lot to all of us.
Yes, thanks for having me. Yes, I am here at the hospital right now. As you said earlier, I am the medical director of the emergency department. So I am an emergency medicine physician that's been practicing for over 10 years, but I'm also the chief medical officer of the hospital here at New Orleans East Hospital. So I've actually been able to see both aspects of the pandemic. I've been able to participate in actually the patient care aspect in the beginning when we first identified our first case. So I was actually an emergency room physician at the time, and then had to quickly pivot into the executive role in order to make sure we had all of the resources needed for us to continue managing these patients. We went from having one census in the emergency department as well as an inpatient census, and within a week had almost triple the census of patients that we're typically used to caring for. We had to increase our resources that we already had. We had to increase our hospitalist services, our ICU services. We had to increase our anesthesia services to being a 24/7 type operation. These patients were sick. They were rapidly declining. So we needed to make sure that we had all of the services necessary to care for the high volume of the patients that we had all at one time. So it's interesting to me because I did get to experience both aspects, and we continue to experience it. We definitely had to make sure that we had enough PPE. Luckily, we were a part of a system that did help us manage that. So from a testing and protective equipment standpoint, we did have some help in that area. So we never were at the point where we totally ran out. We had system support. We also had community support. That was one thing that was nice about this, is that we had support from all around, trying to help make sure that we were able to manage and take care of these patients. We talk about flattening the curve over here a lot, and social distancing is part of that. We continue to do the social distancing to make sure that we can continue to see a flattening of the curve. We are cautiously optimistic. I do not think we're out of the woods yet. We still have, I think, a long ways to go. But I think that if we can continue with our social distancing, we can continue to see some movement in a positive direction. I will tell you, we also did use our digital health platforms here. We did start to have some telemedicine options that we originally weren't utilizing as much. We utilize that way more now. We use it for the hospital as well as the clinic setting right now, which has been extremely helpful for us. Going forward, I think that we're going to continue to implement these new things that we've been doing for some time. I do not see that this will go away anytime soon. So I think having the support from the state, from the country, and as well as on a local level, that we can continue to manage this and hopefully move forward.
That is really wonderful. Thank you for this broad perspective. One thing that is always interesting for me in these kind of situations is really the personal aspects of seeing that such a big wave coming at you surprisingly, and what does it do to somebody personally, right? In such an important position of just like you said, initially you were on the front line, literally taking care of patients, but also had this responsibility as a chief medical officer, right, and the head of an emergency department, to really in real time start taking care of an evolving situation that had a lot of uncertainty, right, associated with it. So share with us a little bit of your personal feeling, thoughts, how you handled it. It's very interesting to learn from you a little bit, because you guys were really on the front line of this.
We did this all together from a front line standpoint. Providers, the nurses, ancillary staff, executive team, we did everything. Really, we came together as a group. We had a safety huddle that we would do on a daily basis. We would be there for like an hour, just making sure that we were supportive for each other and came up with a plan as a group as to what we needed to do in order to make things better for the patients, but also to make things better for ourselves. We recognized early on that this was going to be a marathon. So we tried to put some processes in place from the beginning that would try and make sure that we could not only take care of our patients, but take care of ourselves as well. We have kind of like a wellness floor here at our hospital that's actually available to us on a daily basis. We do encourage our staff to use that as much as possible, and ourselves as well. Our executive team, we try to visit it as well, because we've been here often as well. You know, you think about the front lines, but you also do have the executive team who's here pretty much every day, all day as well, to make sure that they all have what they need. We round on a regular basis, pretty much on a daily basis. Oftentimes we were around in the morning and we were around in the afternoon, just to make sure that everyone who was taking care of our patients had everything that they need to be able to take care of them successfully. And so having to make sure that we had the mental well-being to care, I think that was what was necessary to be able to continue to care for the patients.
That's wonderful. And tell me a little bit more about you talked about the community support, right? So the hospital becomes the hub of the community, the place for comfort, for people to really believe that, if something wrong happens, you guys are there for them. A lot of people looked up to you, right, as the place of last resort, and of course everybody was literally stopping the economy, stopping everything else to make sure that you're not you were inundated for sure, and under a lot of pressure, but alleviate as much pressure as possible. Tell me a bit about the role of the community in this kind of environment, and maybe an anecdote or just like your thoughts about the synergies between the community and you and the hospital and your staff.
We actually have and continue to have an outpouring of support from our community, whether or not it's food donations versus PPE donations. We get PPE and food donations on a daily basis, which has actually been very nice, especially when we thought we were going to get to the point where we were going to be very limited from a PPE standpoint. We never really got to that point because from a system standpoint, we had help, but we also had help from the community. We still get PPE donations. We got a shipload donated earlier this week, and I think we have more coming today. So that's been actually very nice. The community support has been great, and the community support for different services who are not utilized as much has been helpful. Meaning, since everything is pretty much closed down, you can't really go into food establishments like you typically would. So from a donation standpoint, it's actually helpful for the food establishments that haven't been able to have as much people come through. A lot of the people who are doing donations are making sure that they use the services and the restaurants that are nearby to support them as well. So I look at it as twofold. It's actually helping us as a hospital, but it's also helping the community and make sure that they stay afloat as well.
Absolutely, and we're all in this together, and we wanted to. I'm really delighted that you're with us today on the panel. I want to say heartfelt thanks from all of us. I mean, we are all in this together, and hearing that the community has supported you and will continue to support you is heartwarming. And I think that, what I want to do now, some idea that came up in the team, because this is a global conference. The beautiful thing about this conference is this summit actually is a global summit, that runs around the world. And we have people in dozens of countries that are watching this thing, and in 10 countries that are actually managing these things. And what we did is we actually invited people all over the world to join us now, right, and in the live feed, to thank you, to really thank you from the bottom of our hearts together, our collective hearts, because we are all in this together, not only in this country, not only in New Orleans itself, like your immediate community, not only in this country that is all supportive of what you're doing, and you're seeing people, we're seeing somebody from Canada in the background, we have people from all over the world right now who are joining us in this, because we are one community. We're all in this together. You see that, the first time for many years, we're seeing that a threat that happens in one side of the world very quickly spreads everywhere. And it makes us one humanity, because the only way to deal with these things is together. So what we wanted to do is really ask for everybody who's with us on the line together all over the world to stand up and give you a standing ovation, you and your team, and really all the healthcare workers in the United States and around the world, in Italy, in China, in France, in Africa, everywhere. It's just amazing people that are doing amazing things. I will stand up as well. And we're going to join you now for a great standing ovation to Dr. Robinson and all the healthcare workers around the world.
Thank you guys so much.
Standing ovation.
We really appreciate it here from New Orleans.
Absolutely. Thank you so much. And thank you for everybody who joined us from everywhere. We really, really appreciate that. And we will continue with the program, but hopefully Dr. Robinson can stay with us and continue to weigh in the panel itself. And I want to move forward and open the conversation to Dr. Peter Yellowlees, who is actually also working with the health and well-being and mental well-being of some health workers as well. So not only the health and well-being of all of us at home, but also with other people who are on the front line dealing with this. So Peter, can you please join us? And I'd love to hear your thoughts.
Sure. Well, thank you very much indeed, Ron. I must say it's a great honor to be here with so many impressive people who are doing such great things. So, I mean, here at UC Davis in Sacramento, I mean, I actually had 3 different roles in terms of COVID. I'm a psychiatrist and I have my own patients, and I'm treating, a number of people in their homes. We're 100% treating people on video now. And have transformed, the majority of our general outpatient clinics to video. But in mental health and psychiatry, we're 100%. And that's something we've done very successfully. So my second role is I'm the Chief Wellness Officer for our whole system. So I'm also very heavily involved in actually assisting with all of our first responders, people like Dr. Robinson and people who are in our ED, our ICU, our primary care units, who are, at risk of exposure. And so we're running a whole series of support programs for those people. Almost inevitably, they're all on Zoom. And we're getting really good at doing Zoom conferences, Zoom support sessions, Zoom groups, Zoom educational things. We do all of our resident supervision on Zoom, as well as we have some video through our EMR as well. But essentially, we've moved to a completely electronic platform and are providing quite a lot of services and support for our primary care responders. And then I guess the third area that is my area of expertise is clearly on the technology side. And so I'm working across our system to ensure that these things are available and that we can, in fact, really change long term. And I think one of the silver linings that we're going to see out of this, what is a sort of slow moving disaster now, is that all health systems will be using a lot more video and a lot more technology generally to see patients. I think we've gone beyond the tipping point now. Patients, as we know, love being treated like this. Generally, it's much more convenient and much more accessible. And I think it's going to be very hard to go backwards. And to go in reverse to where we were before now that so many regulations have been changed and we have a much freer system. So it's going to be interesting to see how we go forward in this new world. But I think there will be some silver linings from COVID, and getting the health system to change and become more electronically enabled, I think is going to be one of them.
Absolutely, absolutely. So, flipping the coin to the other side, to the provider side of the equation and the changes, the Dr. Yellowlees just shared with us how almost all of their work moved into virtual channels, out of necessity in the past few weeks, and it's obviously transforming the way we're doing things. And just from a practitioner perspective, Dr. Livingston. Jeff Livingston is joining us from Texas. Tell us a little bit about, so telepsychiatry, something that Dr. Yellowlees has been doing for many, many years, and he has shown the road for way before it was a necessity and went up this learning curve. How does it work in an OBGYN practice, and let's talk about, you know, the opportunity, but also the challenges that it imposes on, you know, the doctor side of the equation.
No, thanks, Ron. That's a great question. And our practice, we've been using telehealth to some degree. I've been involved with you through HealthTap since 2011. And, you know, we've sort of just been nibbling at the edges. And we've always wanted to integrate telehealth at scale. And, you know, I think it's interesting when a new disruptive technology comes about, it's different when it's something you want to do, when all of a sudden it becomes something you have to do. So telehealth for the last 10 years has been something I wanted to do, and I had about an hour and a half to implement it immediately into our practice. Now, pregnancy is a very interesting challenge during a pandemic. It's really interesting, but the fetuses don't really care. They still plan to come out. Pregnant women still plan to go into labor. And from a private practice OBGYN point of view, this is exceptionally challenging. Some specialties can staff down. They can decrease their staffing ratios and decrease the overhead of their practice. OBGYN, we can't do that. We need to continue to see the patients and then find technological solutions to decrease their risk of exposure. But we still need to be there to care for pregnancy. We did some things with telehealth that has been very successful. So a lot of our gynecology, contraceptive counseling, our postpartum counseling, all of that was easy to transition to telehealth. Some of it, I think, sticks around when this is all over. So I'll just give you sort of three kind of examples. One, we've done in-office childbirth, pre-Lamaze type classes for years. When we switched it to telehealth, we 10x'd our attendance. Kind of interesting. I think number one, it was the convenience of doing it at home, although perhaps there's an element of moms just needing a break from their children and being quarantined at home. But our attendance skyrocketed. I actually think this is a much better way of doing it. Our second example was our gestational diabetes class. Rolling that over into telemedicine, our compliance went up and our patient satisfaction went up. Our third example, we've been running a live postpartum depression support group for a while now. When we converted that to telehealth, attendance also went up. I think in those three scenarios, these are all things that stick around once this is over. I do agree with the previous speaker. With the decrease in regulations, telehealth has reached the tipping point. I will counter in that it's not actually sustainable at the level that we're doing it. For example, I sent you a funny article which showed the coding requirements just for Texas. And I think you and I shared a good laugh. There's 35 different codes for the various insurance companies. There's no way, there is no way every doctor in the United States is going to memorize the 17 different ways to code a telehealth for each different payer. That doesn't make sense. So while the lack of regulation allowed us to scale, there's got to be some sort of organized process so that this can continue once the pandemic is over.
Yeah. So that's a great segue to Dr. Reed Tuckson, who has some good expertise around, of course, as being a senior executive at United Healthcare, one of actually the largest health insurance company in the country. He has a good perspective around these things. So Reed, you know, doctors are saying, you know, there's a great opportunity in telehealth, but it's extremely complex when the payers are amassing, you know, all kind of recording taxes. So how do we, what can you tell us more about that, about opportunities, but also the challenges from all perspectives, because it's a challenge for everybody, not just for the doctors.
Well, I was privileged to be the Executive Vice President and Chief of Medical Affairs for United Health Group. And there we had both the insurance side as well as the provision of services side. And as you see now, companies like Optum, which is part of United Health Group, are very much involved in it. I think what we have here is, let's remember the context. The context is the healthcare costs were going up so rapidly. And so many sections of America can simply not afford any more costs. And so there was this, and have has to be a huge interest at trying to bring down unit costs. That means supply chain non-redundancy. It means minimum services at the hospital and right sizing those hospitals. And now we've seen, in fact, the danger of all of that. And so looking to the future, inevitably telemedicine is something that its day has come. It is mainstream. When I was president of the American Telemedicine Association a few years ago, my very first slide in front of the convention was telemedicine is now mainstream. Here's what we have to think about going forward. First of all, Medicare has made some important changes in how reimbursement will be made, providing telehealth services the same as in-person care, removing site of care restrictions so that in-home services will be able to be covered, making sure that now that audio only for this temporary period anyway, in addition to having video capabilities in real time now covered. We now have removed the provision for pre-existing relationship with the patient. Used to be had to have a relationship for 3 years. Now that's gone. So there are a number of those kinds of things. Will those things be able to be turned off by Medicare? I think it's going to be very difficult to turn those things off. But the challenge, as Jeff sort of indicates, though, that while there's also great variability in Medicaid and how the states will implement this, and there's variability for how private insurers. I think that we'll see the coding issues affected and modified by what the American Medical Association with its coding opportunities will, I think, be able to bring a lot of clarity to that. But at the end of the day, we're going to see much more care delivered outside of the hospital, even as we worry about how to deal with redundancy and the ability to scale up for a crisis. You still will have the downward pressures of cost control that will drive things continually outside of the hospital. And now that physicians will become more comfortable, the rate limiting step in any new technology is whether the culture of physicians are willing to accept it. Well, the learning curve, as Jeff and Candace have said, is like that. It's moving so fast. So now that issue will start to be put to the side. And I think now we'll start to see a much more rapid movement across the board. I'll conclude with this one thing though. You've made a comment a couple of times that we're all in this together, and that is true theoretically. But there are still communities in our country who are not in it. That people of color, people who are poor, lower socioeconomic status, they are still struggling with this crisis very much, and their needs are not being addressed with the specificity or urgency. And so that in New Orleans or in places in rural Louisiana, they don't have broadband access to allow these services to fully express themselves. So there's a lot of work to do to make sure that while we want all of us to be in it together, some of us are still lagging behind.
I think that's a great point. Thank you for bringing it up. That definitely was one of the topics that I wanted to cover here, because it's not only that there's a challenge for these people to access care. What's happening, the flip side of COVID-19, everybody is so distracted dealing with the virus, which is obviously important because it's a life threat for elderly people and so many people in the population. But at the same time, what we're doing to actually support that is also stopping the economy as a whole. And what's happening is an unfortunate, I don't know if unforeseen, but a circumstance where when unemployment goes up dramatically and the resources go less and less to the weakest people in our community, actually the hardest hit people are the ones that have the least access to care. Yeah. And it's a vicious cycle because you're basically weakening the weakest, right? And taking away from them access to care that otherwise was available to them through an employer. And millions of people are joining exactly the group that you are talking about right now, literally by the minute right now, right? And it will take time. I mean, as we all know, it's not going to end up in one day when the whole thing stops. And I think that it's a very, very important point to address in this conversation. And I wanna bring it back to this conversation, maybe through to a conversation with Josh Reef from Onduo. I know that Josh, you're also dealing with more specialty care and things that are related to Dr. Livingston talked about diabetes, right? And about how gestational diabetes was a great way to actually provide virtual care and get more participation. And we know that in weaker communities, a lot of these chronic conditions are prevalent. What is your view about really how we can use technology, how we can use the next generation of health to provide support to people in need?
Yeah, thank you. And before I start, I want to second and third the applause for Candace. I'm a emergency medicine trained physician also, and I look to my colleagues like you with admiration, respect, and I don't think the country could be in the place where we are today without people like you. So thank you. So Ron, to answer your question for digital health, you know, I agree with Dr. Tuckson with one caveat. The digital health has been around for a while. People are using it out of necessity today. And I think the convenience factor has always been there. I think we have to figure out two things though to really get mass adoption. Because like I said, the convenience has always been there. It's always been relatively inconvenient to drive to doctor's office, park, go wait in the waiting room. But there's a degree of quality and trust that you get with a human being or somebody who's a known entity. And then I think the doctor's willingness to use the technology was one barrier, but the other barrier is brick and mortar overhead. And until health plans start reimbursing for outcomes and reimbursing digital health at the same level as a brick and mortar visit, a doctor's motivation is going to be to cover his overhead or her overhead and to cover her nurses and to cover her staff. And the motivation is always going to be, well, just come in and see me. It's easier. You know, I could do the biopsy if I have to. I could push on your belly if I have to. So if we all as a nation recognize that this is a way of solving many problems, including socioeconomic status and access, and rural America getting access to some of the best providers in the country. If the payers will start reimbursing digital health in a similar manner to brick and mortar, the doctors are now comfortable, the patients are testing it, I think now this is a perfect storm. Again, though, when COVID ends, the thing that has to have happened is doctors have used it and said, I like it. Patients have used it and said, I like it, but we have to see reimbursement reform such that, you know, like Medicare patients could get access to telemedicine or doctors are allowed to get reimbursed for telemedicine. I think when we see that, we're going to see some great progress. In my own experience at Onduo, we made a massive bet on telemedicine 3 years ago. So we're a virtual clinic that provides care to people with diabetes. Our bet was that all these, you know, meter and gadget companies that do lifestyle aren't enough. That's great for maybe 40, 50% that want to wear a Fitbit or they just want a connected blood glucose meter. But if you can't get access to doctors, you know, you get, you know, 3/4 of the way there. Once you add in telemedicine, you could really help those who need the most help, which are usually that 20%. So we've been offering virtual care. We've done all corners of the country. We published a study that showed that a greatest proportion of the people whose A1Cs we dropped were in rural America. And this is the perfect way for chronic care to be delivered. Acute episodic care, which is where the majority of telemedicine has traditionally focused. What Dr. Robinson does in the clinic, what urgent cares do, huge component of a physical exam there. There's high urgency, there's high need, and there's relatively, it's not that hard to get to urgent care. For chronic diseases, there's super low motivation. Reed will probably remember this. He did a whole program where they had famous people, like movie stars, talk about diabetes, and people listen to the movie stars because the motivation to manage chronic diseases is so low. If you could lower that barrier to access, we could actually potentially get people to engage, and that's what Onduo has been doing for the last couple of years.
Yeah, and that's really interesting because when you start seeing things unpacking with COVID-19, one of the things that really concerned me was to see the rate in which people with comorbidities, right, were affected even worse by the virus. And again, back to populations that tend to be, you know, low income, higher rate of comorbidities, right, and in certain areas were affected a lot in a lot worse way. And I think that's like, you know, the whole notion of what you're talking about, Jeff, and would like to bring Don Jones into the conversation as well, is like, we're thinking about telemedicine a lot, or telehealth, we're a lot of time thinking about primary care, we're a lot of time thinking about urgent care, right? Like kind of like simple things, cold, coughing, all these kind of things. But we had both Dr. Livingston and also Josh speak about specialty care. But Don, I'd love to hear from you, particularly in the context of the weaker part of the population. Is there an opportunity to bring telehealth and also extension of telehealth, like Josh mentioned, devices and other things, and to point, this kind of concept to people that are weaker, to give them access that is less expensive and easier to care, right? Is there a path to that via better technology? So Don, if you can join us for this.
Thank you, and thank you to everybody that's on the front line. In my previous life, I was Chief Operating Officer of American Medical Response, and I also helped build MCare, the largest medical group in the United States, with a lot of emergency physicians, other in-hospital physicians. So I've been there with you at different parts of my life. There's a lot of interesting things going on. Josh knows at Onduo, they make a big use of Dexcom, which is continuous glucose monitoring, for essentially remote monitoring, both to give immediate feedback to the patient, but also to the providers. And interestingly enough, just this week, Dexcom has provided 100,000 units for the ICU for continuous monitoring of patients in the ICU. So providers don't actually have to go get additional exposure with the patient. So here's remote monitoring technology now being moved into the hospital through a rapid FDA approval of that use. So an interesting reapplication. At Scripps Research, we have just launched the DETECT study, where we're enrolling hopefully 1 million folks using activity monitors, specifically with heart rate tracking, into a model to see whether we can detect the virus earlier, using the various vital signs of the activity monitor, as well as some patient-reported information. That study's launched, and the first roughly 10,000 people have just enrolled this week. It's going very fast. Fitbit's a partner. Most of the wearable companies are partners and promoting it out through their wearables. So there's an example of taking inexpensive technology and put it into the possibility of remote detection. Another interesting play has come out of CMS. CMS had a program that wasn't yet launched called ET3, or Emergency Transport 3. They have effective.
Okay. I think
the program being launchable. Am I losing? How do I sound?
Just for a second, but it's okay. I think that now you're back. It's all good.
So today you can actually in the field communicate with a physician and can arrange a telemedicine consult in the field. The paramedic service can still get paid as if they don't transport the patient to the hospital. They can also now have permission to transport patients to non-emergent departments, alternative destinations. Neither of these things were possible 10 days ago. They were being proposed, but now they're in place. So this is, again, going to drive a telemedicine application, but it's also driving the concept of alternative destinations, which will be especially important in the mental health field, where mental health patients can be better treated at specialty mental health facilities rather than in the emergency departments. So we'll see that potentially take hold. It was a program that CMS was going to launch anyway. So now we're seeing elements of it be launchable. And then finally, an interesting program's happened in England at NHS, where they've moved huge field hospitals that are in stadiums. There's at least 3 of them that I'm aware of. And in all those cases, a San Diego company called Trice Imaging has managed to connect the ultrasound machines, the mobile ultrasound machines that they've taken into the stadiums, so that the ultrasounds can be read remotely, but the ultrasound technicians can work with the populations in the stadiums. And so they quickly have brought up equipment from Philips and from GE and from Siemens and other ultrasound manufacturers, and instantaneously brought them online. Many of these pieces of equipment were never designed to be online in the first place, and now they were through this remote technology. So a lot of new applications. A lot of times the technology was already there. It's the need element has now caused people to say, well, we'll reapply this in new ways that we weren't motivated to perhaps before.
And that's wonderful. So I want to bounce back to Reed, actually, like talk about Reed. I'm hearing a lot of, like, in all channels about accelerated innovation, accelerated change on the regulatory environment. You mentioned a little bit of that, how quickly, we were literally fighting for 20 years to try to do something about, practicing across state lines. And all of a sudden, like in one day, the whole thing disappeared, right? And allows physicians to just take care of patients, period, right? Which is, more logical. All kind of easements around HIPAA, and again, patient privacy is extremely important. But, a lot of the archaic things that prevented, medical professionals to access people, particularly people in need, all of a sudden went away very, very quickly. So we're seeing accelerated innovation, right? On the technology side, on the application side, we're seeing accelerated movement on the regulatory area. Are we going to see the same accelerated rate of adoption on the payer side of the equation, right? To actually adjust to these things quickly enough so they can be available to people quickly and not slow down things as we had seen before?
Well, first of all, I'm a true believer, and I'm an optimist, and I'm an excited kind of person. However, I'm also a realist, and we have to remember the complexity under which the American healthcare system works. People get their healthcare in the private sector through combinations. They get their healthcare because certain employers will hire insurance companies to administer benefits on their behalf. The employers have specific criteria around benefit design and what that looks like and what it will cover. So we will have to hope that the employer community will get on board after this crisis is over and continue. Similarly, the insurance companies themselves for their self-insured population have certain requirements. And then the insurance companies work on behalf of state Medicaid agencies, which have their criteria. And then you have the federal CMS. So and then you have people buying different kinds of packages. Some have more or less flexibility and freedom in it. So we don't know what's going to happen downstream. Certainly there will be change. But let's also remember this, and again, I am a true believer in telehealth, former president of the American Telemedicine Association. We're going to have to make sure, though, that these services prove not only their utility in crisis, but their value in terms of quality and their value in terms of cost effectiveness. I mentioned at the very beginning of my comments a moment ago, the real challenge we have in America is the unaffordability of healthcare. So somehow or another, going forward, you can expect there will be a demand for redundancy in the supply chain for hospitals and healthcare facilities. You can expect there will be a redundancy for making sure that we staff up enough beds, even though we're trying to limit the use of the hospital. Somebody is going to have to pay for that. And the American people are tapped out on their ability to afford any more healthcare costs. So telemedicine and telehealth will have to be used intelligently, effectively, and we're going to have to, the true believers, the zealots that are doing this, are going to have to show that we're not adding costs to healthcare at the same time that we're saying we're doing all these good things. That's the challenge going forward.
Absolutely, and I think that I'll open it to the panel as a whole, and you can raise your hand or just chime in. But I'm very, very excited about what Reed just said now, because I think that on the one hand, we have all the payers, the traditional payers, and as you can see, most of them are pointed to the haves in our community, right? So people who are employed, people who have access to sophisticated insurance plans, obviously will have one way or the other access to virtual channels as well. What I'm more interested in and more concerned about are the millions and millions of people. And unfortunately, it is the fastest growing number right now in the background. So let's remember that of people who are unemployed, right? People who their resources are very, very limited right now. People that are in true need, a lot of them have a tremendous number of complications and comorbidities and exposure to more because their lifestyle is for the access to healthy food and access to healthy resources is very, very limited. So this weak part of the population on the one hand, but what I'm hearing from Dr. Jeff Livingston when I talked with him about this thing on the other side of the equation, we have tens of thousands of doctors who are losing their job by the minute, right? And you know, I read somewhere that by the end of next month, if things continue this way, we're going to have 68,000 unemployed primary care physicians in this country. I mean, this is a mind-blowing number. So what can we do, right? And there's a very smart panel here to bridge this gap of, like, you know, excess supply on the one hand and excess demand on the other hand, and use the fact that we have a channel that is less expensive, more affordable, to actually take care of two issues at the same time. But think about also the, you know, the payment part and sustainability for it. So I'll open it up to whomever would like to discuss this.
Yeah, Ron, can I respond to that? So,
sure.
Yeah, so thank you for bringing up the cash flow issue, because I think, you know, for those of us that are just in private practice and not necessarily hit in an area where COVID is striking, it's a domino effect. So when a physician maintains a full practice and full staffing and complies with what's provided in the CARE Act, you still create an unsustainable cash flow as your revenue drops to 10 to 20% of the pre-COVID. I don't think people understand how fast the doctors will fail. It's happening now. I am stuck in my glasses. I cannot get my contacts filled. My eye doctor has already closed, okay? I wanna answer your question though, because I think this will springboard into the topic. So when we talk about solving this problem, I think Reed's answer was so great because it showed the complexity of the healthcare system. And no doubt, I agree with all of that. But how do we solve that and answer your question to how do we get to those in most need? You know what you need? You need leaders. That's what people get paid to do, to be the leaders. So do you know who can solve this tomorrow? The CEOs of the largest health insurance companies in the world. They can sit back, meet with smart people, and come up with an action plan to provide change at scale. Do you know who else can initiate change? In my state, Governor Abbott. What can he do tomorrow? He can authorize state Medicaid plans to cover this. He can authorize coverage through the FQHC program. He can authorize coverage through Title X. So can governors in every state. Do you know who else can change it? City leaders, mayors, senators, representatives. And I'll be quiet, but I want to compliment my congressman. I've never once called a congressman in my entire life. I've never done that. That's just not something I do. But I called our congressman, Congressman Michael Burgess, Republican from Texas. I called his office. They called me back. I got to have a conference call with his legislative assistant. The following day, he was sitting in a House committee on small business and health. All citizens on this call out your leaders, call them, express yourself, and make our leaders stand up and lead.
Thank you for that. More views on that. I'm opening it to the panel.
So I'm interested to comment, I mean, on exactly that issue with taking the California perspective, where in fact a lot of that has already happened. And, you know, the California governor and the assembly has actually passed laws within the last few weeks to insist that, you know, telehealth across the whole groupings and disciplines is paid at the same rates as as in-person care. And now, that's going through the system now. I mean, you know, we have those regulations as far as I know. And I think it's going to be an interesting example. I mean, we've certainly as a health system been able to switch very radically across from, you know, 3 to 5% of total video consults, you know, to in the sort of 30s and 40s for general medicine and surgery and, you know, pediatrics, areas like that. And as I say, to 100% for psychiatry. Now, I mean, I'm just as busy as a psychiatrist now. In fact, I'm actually busier than I was before COVID. I'm seeing more patients. So are all my colleagues. And so part of this is a distribution issue, as you correctly say, Jeff. I think, you know, we've got the usual problem in that there are different situations in different states. But I do think people should look at the California model where we're going in that direction.
I agree.
Yeah.
Yes.
Yeah, I mean, I'd add one small caveat to it, which is there's a lot of digital health providers today who are doing an amazing job who are not traditional brick and mortar systems. And I think one of the things we also have to be very cautious of is that brick and mortar has to make some investments. You need to buy a CAT scanner, you might need to buy an MRI. And if too much switches to digital, there is in digital independent providers, there is a chance that you could start eroding the base of some of these healthcare systems that we need. If Dr. Robinson didn't have an ER to show up to, we'd be in a lot of trouble right now. And so I think part of this is finding the right balance of bricks and clicks. I think retail, I used to be at Target, they did a pretty good job at figuring out how do you maintain the stores, but then also develop a .com presence. And because of that, they have a place in this ecosystem. I think healthcare, the traditional brick and mortar healthcare systems have to find that right balance of bricks and clicks, such that there is an ecosystem that the health systems could still sustain, and it's not completely fragmented into these, companies like I run, that it's all, health startups and healthcare companies that are willing to make that investment. And I think if the pendulum swings too far to one side, we also put ourselves in jeopardy.
And just very briefly, I mean, as a local example, I mean, we are looking actively now at the size of our outpatient clinics, and can we actually reduce the amount of bricks and mortar that we have, because we've got, so many physicians who actually like working at home.
Yeah. Bricks. I like bricks and clicks, right?
So I do too. I like that.
In the spirit,
not mine, but that's a good term.
In the spirit of we're all in this together, I think that it's important to remember that, as much as we are going to see a big shift into telehealth and telemedicine and the digital side of the equation, we need to remember that there's some important part of the healthcare system that they need to continue staying strong. I mean, Reed talked about that, on redundancies, on really being ready for the next pandemic or the next threat that will come to us and will require people to be in ICUs or in other places where they actually get care. And I think that it's important to remember, as much as we believe, and I talk with a lot of people in the industry, that telemedicine is going from a low single-digit percentage of adoption to likely more than 50%. And we've seen entities like Kaiser Permanente, particularly in Southern California, moving more than half their practice to virtual channels. So we know that this is not only sustainable, but it can be also very profitable for healthcare systems to go and adopt these virtual channels at large. And I think we will have a catalyzer to do that now, and we're going to see a really strong movement into that. And it's not going to be the gradual movement that we saw before, but we need to remember, just like Peter said, just like Josh said, just like Reed said, just like Jeff is practicing, that we need to also remember to keep the practice and the delivery side of the equation strong. And we started with Dr. Robinson, and I want to end with Dr. Robinson because I think that's something that inspired me beyond the unbelievable work that she and her team and her colleagues and all the healthcare workers are doing on the front line day in and day out, literally endangering their lives and giving their lives to all of us, is that when she described what they've done and how they prepared and how they failed, she also described that they themselves moved part of their work to virtual channels as well at the same time. They were giving people love and expertise with their hands and their heart. So I'll hand it off to you to say some parting words for the panel, Dr. Robinson.
Well, in reference to the telehealth aspect, I will have to say that while I agree with everyone saying that this is definitely a good platform for us to move towards, I cannot get off of this call without at least commenting on the fact of being concerned about telehealth in worsening the disparities that we see right now. Because I'm sure that you've all seen that we do have definitely some significant disparities to discuss in terms of COVID-19. From a telehealth standpoint, we have had a lot of our patients embrace it, but we also have a lot of patients that can't do it because they don't have a phone or they don't have an iPad We've actually had to stand up 2 separate tents to be able to accommodate our patients because some of them don't drive cars. So we couldn't do strictly a drive-through. We actually had to set up something where we actually could have people walk up because we knew they couldn't drive. So I agree with Jeff and when he was saying from a leadership standpoint that I think that we definitely could move towards more telehealth, but I think we need to have the support to make sure that it could be equally distributed in order to have the most impact from a patient population standpoint. So I agree, I'm all for telehealth, but I think it definitely needs to be within reason to make sure we are giving everyone the proper access to care.
And thank you so much for ending it on this note. I can't agree with you more. I mean, this is, we really, our heart is with everybody. We want to make sure that we, as we're moving towards, technology disrupting and changing and making everybody's life better, let's make sure that we're highlighting the word everybody. And everybody includes everybody, right? So, and remember that as we're moving quickly towards new channels, we cannot for even a second remember the weakest part of our community, and we need to make sure that they're brought together with us into this new world. And how we support it, maybe there is a role for our leaders, just like Jeff said, to really consider how we allocate resources to make sure that these people are brought with us together into the next generation of the world. And how do we prepare for the next thing that we can't foresee right now, and be more prepared to it than what we have been for this one. But most importantly, Dr. Robinson, thank you so much really for everything that you and your colleagues are doing. Thank you so much for the love and the support. Thank you to all the panelists, the amazing panel that was wonderful this morning, for coming and sharing with us this panel and this really thoughtful and meaningful group of people that again came together. We are all in this together. We're on the front lines of taking care of patients, whether it's in the hospital, whether it's in the clinic, on the policy side of the equation, on the insurance and payer side of the equation, startups that are very successful in changing things, but also big companies and executives, and just like Jeff said, our leaders. We all need to come together, and not only in this country, just like in the global standing ovation, that we gave to all the healthcare workers and Dr. Robinson in the front. We need to remember that we're all in this together, and we need to solve this as a humanity and never ever leave anybody behind. So thank you so much to everybody, and we have with us a really an amazing treat, so you can stay with us on the line for that. Alice Phoebe Liu, who's an artist and a singer, is going to join us right now to end this panel and prepare to the next panel that will cover the mental well-being aspect that all of us are very familiar with, and Dr. Robinson mentioned as well. And between that and that, we wanted to have a little moment to just feel. We've been doing a lot of thinking, and we want to feel a little bit. And Alice is just an amazing artist. She is a singer. She's a songwriter. She released 3 albums, and actually one of her songs was called "Her" was shortlisted for an Oscar a few years ago. So we're very delighted and honored to have an amazing panel. Once again, I'll say quick thank you, Dr. Peter Yellowlees, Dr. Josh Reef, Dr. Reed Tuckson, Don Jones, and Dr. Jeff Livingston, and of course, Dr. Robinson. Thank you so much for joining us, and let me please give a very warm welcome to Alice Phoebe Liu.
Thank you so much. Thanks for having me. I'm really happy to be here, and I've just had a wonderful time listening to you guys, and Dr. Robinson's words just nearly brought me to tears. So I don't have much to say. I'm just here for a little bit of catharsis, and hopefully just to lead you into the next round, and have a beautiful day. It's evening here in Berlin. This song is called Girl on an Island, and I hope it's soothing for you.
There once instincts are not fed, well, you're not free. You don't feel free. There's no time to be on that island with me, far away from the city, from the litter and poverty, from the past, and north and east.
Thanks. I'll see you guys later. I'm playing some more songs in a bit.
Thank you, Alice. Thank you. Thank you so much, Alice. Really, really appreciate it. And Alice mentioned it, but I should have said it. Alice is joining us from Germany. It's quite late at night, her time in Berlin. We had a wonderful conversation about, how it was a little bit sunnier in Berlin in the last few days, and there was like hope coming up when people started like walking out in the parks and, starting to, slowly going back to, back to normal life, and it was beautiful to hear you singing. So thank you so much for taking the time. It was wonderful, and you are going to be with us for a longer performance in about an hour from now.
Yeah, I'll see